excited to share this topic with you today. We have two of our amazing faculty from our Colleges of Medicine and College of Nursing, Doctors Hector Chapa and Shelley White-Corey, and I'm very thrilled to turn things over to them.
Thank you, Chris. Hey, everybody. It's glad to see everyone, both from Texas and obviously from other locations. I have to tell you, we're going to stick to our time, number one. Two, it's not going to be boring. And then three, I want it to be very applicable because that's what we're here for. And Dr. Finkelstein, I'm telling you, as an ER physician, I'm an OBGYN by practice. I'm still in clinical practice here in Bryan College Station. But I'm also the clerkship director for OBGYN here for A&M. But I'm telling you, anything that's acute, that's your house, right? So emergency medicine, or even if it's internal medicine, it doesn't matter. We've got to do this different. And in true disclosure, I didn't learn this in training. I mean, I trained in Dallas, and it was medicine did what medicine did, and nursing, you know, God bless them, who knows what they do, but we just need them to show up. We can't do that anymore. That's not appropriate. So I had to learn this since my arrival here in A&M in 2015. And I'm telling you, it's fantastic. The things that we're doing with Dr. White-Corey, it's a blast. The students love it, but above all, we're getting our future healthcare providers just to be better than how we trained. So having said that, very easy. None of that's the objectives, by the way. That's just personal perspective. Three main objectives, super easy. You have to know what IPE even is, because I didn't know what that was. So how do you define IPE? So if somebody asks you in the hallway, you know what it is. It's super easy. And of course, not just to know what it is, but why it matters. I had to learn that, and we're going to do that in 5 minutes. We're going to summarize how we got here. It's not going to be boring. Nobody wants to hear history, I get it. But unless you understand where we were, it's hard to really appreciate where we are. So that history is fantastic, no more than 2 or 3 slides or so, and it's going to show you that this didn't pop up overnight. It wasn't part of LCME or the nursing board saying we need them to check off more boxes. This happened over about 30 years, and boom, it just took off. So fantastic. I'm going to show you a little bit of that history. And then last, the topic of what we're doing here is, what does that look like? You have to have something to measure, and that's called a core competency. Again, I had to learn these, and I know these cold now because of what I do, and I'm thankful for it. We're going to review 4 master core competencies and then the list that each one has, because each core competency has a lot of children. Notice how I get that plug in as OBGYN. So I have to stick that in there somewhere. So we're going to cover all that very quickly. Miss Chris, next slide. So here it is, very easy. Somebody asked in the hallway. We had our medical students learn this for our recent accreditation, which we got a full pass. I'm very thankful at College of Medicine. Here it is. Interprofessional education, which, by the way, guys, is not just about healthcare. I mean, you can do this with any professional society. The DOD does this. The military, I'm part of the Texas Guard. We learn team steps in the military. So IPE is when 2 or more professions, 2 or more groups, learn about, from, and with, as a community, with each other, so that we can all get better outcomes. That's all. But those are the 3 hot words that everybody's looking for. Learn about, from, and with, not just to check off a box, to affect outcome. So here's what that means. IPE is to make collaborative, team-ready practices. That's what our group is looking for. So Dr. Feinstein, that's LCME. LCME, AAMC is looking for, are you making team-ready doctors so that they don't come out with a God complex, but a team complex, which is what we've got to get to. And so that's the definition. And it's all about impact. Ms. Chris is going to show us in the next slide why this matters, because the data shows if we do team-ready care, practice-ready physicians, medical students, nursing students, dietitians, whatever, if we work together, 4 things happen. We reduce medical errors. That's number 1. Overall health outcomes improve. Patient satisfaction, which I get a report card every quarter, like I'm in 5th grade, from the patients that I've touched, what my letter rank is, A, B, or C. And the administration loves it because it reduced costs. Pretty much you've covered everything. So this slide is not our opinion. This is data and publication after publication that the 4 main areas are impacted if we can practice as a team and learn from, with, and about each other. Ms. Chris? So here's where it is. Very briefly, we're going to walk down history in a couple of minutes. And it started in the 70s. I was not practicing then, I'm not that old. But it started in the 70s when that term, interprofessional teamwork, first came into a US publication. Isn't that crazy? I mean, you'd figure we'd always know this, but that term, interprofessional teamwork, actually wasn't in print until the mid-70s. Pretty impressive. And then the early 2000s was a big time for medical education and healthcare education overall. And it started in 2000 off the piggyback of, and I'm sure you all have heard this, the report called To Err is Human. To Err is Human shook medicine up, it shook nursing up, because it said over 80% of medical errors in hospitals and clinics and in the ORs are preventable. And the number one reason was bad communication, because we were all practicing by ourselves and not as a team. And you figure we'd know that. That was not until 1999. And that organization called the IOM is now gone. It's now been renamed as the National Academies, the National Academy of Medicine. And that led into, in 2000, when we had this call for a reduction in patient safety. The next year, 2001, now a group of professionals were getting together and saying, well, how do we reduce these errors? How do we improve patient safety? It's easy. We have to be collaborative in our teamwork. We have to start learning together. And again, in 2 years after that, in 2003, they now introduced, wasn't adopted, but they introduced at least a benchmark. All right, everybody with me? Those are the core competencies. That's the focus of what we're talking about here. And again, this is not a medicine thing or a nursing. This is anybody that's involved in a professional duty or role that can work to collaboratively with others, like the military, like psychology. This improves overall outcomes. Now, there's an organization called the Institute for Healthcare Improvement. It's not Leapfrog, that's another group, but the IHI is its own independent body, and they came up with what we should be looking for in IPE, and they came up with 3 main goals. That's called the triple aim. It now includes, thankfully, I'm very thankful for this as a provider, improved clinician experience. So it's a quadruple aim, and that means reduce burnout. Because for OBGYN and Dr. Finkelstein, your group too, man, ER, we're big burnout. It's how do we reduce burnout? So the quadruple aim is now improve care for patients, population health, which is one of our pillars in College of Medicine here at A&M, reduction in costs, and reduction in physician burnout. Because if I can call Miss Shelley and say, Miss Shelley, I'm having a hard time, this patient's burning me out. I mean, I don't know, what's that? I need you to help me out here for a minute. If I can rely on her, it increases our overall wellness. Ms. Chris? Now remember what we talked about. That was from the 70s to 2008. We're now in 2009. In 2009 was a big milestone because these people started to have money into the pot. So they started putting now vested interest by 6 professional accreditation units. And you can see we're on there as well from medicine to say we want to do this differently. So AAMC said we're going to come in and be part of this collaborative. That's called IPEC, the Interprofessional Education Collaborative or Consortium. Those are key letters, IPEC. We're always going to hear that in IPE discussions. And we're going to say, yes, this matters. We need to learn how to practice differently. And not only that, but we're going to contribute by making what's called core competencies. Ms. Shelley, or next slide, please, Chris. And Ms. Shelley is going to take over from here.
So I did exactly what you suggested we be cautious about, Chris, and forgot to unmute. But anyway, thank you, Dr. Chapa. That was a really great presentation of the history. And, you know, it reminds me of that quote by Arthur Clarke that good ideas go through 3 phases. First, people say it can't be done, and then they say, well, it probably can be done, but it's not worth doing. And then they say, oh, it's a good idea, it's worth doing, and we knew it all along. So that's kind of the history of IPE, that it's gone through these phases, and suddenly we're all going, yay, let's do this. But as Dr. Chapa went over, IPEC actually was formed in 2009, and then they came out in 2011 with their 4 core competencies and 8 to 12 sub-competencies each. So the core competencies, as you see on the slide, are values and ethics for interprofessional practice, roles and responsibilities, interprofessional communications, and teams and teamwork. Next slide. So here are just some examples of some of the sub-competencies of the 4 core competencies. And I'm not going to read these to you, but in the parentheses, you can see that the first one is one of the sub-competencies of values and ethics. Second one is a sub-competency of roles and responsibilities. The third for interprofessional communication. And the last one is teams and teamwork. And when we are, well, you'll learn that some of our objectives for our interprofessional activities are based on some of these sub-competencies. Next slide. So I love this slide because it shows how far we've come. In 2009, when the IPEC formed initially, there were only 6 founding professional organizations, and now look at us, 21. 21, and as Dr. Chapa mentioned, the HPAC, the Health Professionals Accreditation Collaboration, formed not too long ago to bring accreditation into their organizations and their healthcare professions to make this an expectation of education. So the initial IPEC core competencies came out in 2011 and were updated in 2016. And there was 3 main purposes for the update. The first one was to reaffirm the original competencies. The second purpose was to organize under a single domain. Initially, the 4 core competencies were each their own domain under IPE, Interprofessional Education, but now all of the competencies fall under an umbrella domain of interprofessional collaboration. And the beauty of this is that it's created a shared taxonomy that supports interprofessional activities, assessment, and evaluation, which is crucial to the progression of interprofessional education. And also the third purpose was then to broaden the competencies to better achieve the triple aim, most specifically including population health, which you can see in this diagram here. The outer circles focus on community and population and patient and family-centered care. Next slide. This is you, Dr. Chapa.
So I love this because you see, anytime that you get a group of educators and administrators together, you take something that sounds just so simple and then you make it competencies and sub-competencies, and that's what happens, right? But because you need something to measure. I love this because this really is a simple issue. Look, we've got to move away from the purple bar on the top left and move towards the bottom hybrid, which is a mixture of 2 different identities. That's all. I need to stop teaching my medical students that when you walk into the room, you're a physician, and that's right, but there's a comma behind you're a physician, comma, and part of a team. Before, it was you are the physician, period, and that was a hard stop. You walk in there, that was you. But the idea was that we've got to get away because you improve patient care when that identity changes. So here we are. So the purple side, or the left-hand side of the top diagram, is professional identity. We're great at teaching our medical students how to be physicians, not so much how to be a good team player. Man, I'm telling you, I sit on the quality board at our local hospital. Half of those things are decision-making, clinical judgment. The other is interprofessional issues, meaning professionalism. You yelled at somebody, hey, we're all human, we all make mistakes, and we all fall. I've done it. But a lot of that can be fixed if we understand that our identity is not just who we are individually, but as a team. So this is very simple. It looks like a complex drawing, and to me, as a gynecologist, it looks like the bladder with an outlet obstruction. But nonetheless, you get that the left-hand side is individual identity, the right-hand side is team identity, and when you merge those two, all that comes out is better outcome. That's all. Again, easy concept, and we need a whole slide to say we do better when we are in the same boat and not fighting each other. And last thing I have to say, I grew up at a major county hospital in Parkland, fantastic staff who would yell at nurses. I mean, just yell just because that's what you did as a doctor. We can't do that anymore. Nobody wins with that mentality. Ms. Shelley, next slide.
So I just have to say that Dr. Chapa has never yelled at me.
I never will, Ms. Shelley.
Never yelled at me. But you know, the great thing about interprofessional education is it gives everyone a voice. And I know in, you know, the history of doctor-nurse relationships, nurses often didn't have their voice. And I'm sure some of you are probably shaking your heads right now that you feel that way with the other professions that you work with. But you know, that's one of the things we really focus on through team steps that you see here, is making sure everyone has a voice and is heard. So team steps is the core competencies in action. Team steps, as Dr. Chapa mentioned earlier, was developed by the Department of Defense in their patient safety program. And it's an evidence-based system that we value highly, right, in health professions, to develop communication and team skills in healthcare professions. So we have really, in our university system, we have really emphasized the importance of team steps in that all our students are trained in team steps. We've just had several faculty who were trained as master team steps facilitators, and we use team steps in the interprofessional simulation that Dr. Chapa and I have led. Next step, the next slide. So we have used team steps and interprofessional education in simulation since 2013. So the College of Medicine and the College of Nursing have come together in simulated cases on obstetrical emergencies like postpartum hemorrhage and hypertensive crises in laboring women. And these are really important things to practice in education, because this is so dependent on teamwork. When you have an emergency, you must come together as a team to be able to improve patient outcomes. Our learning objectives are based on the IPEC Core Competencies, and we do use several of the team steps tools. Specifically the briefs, the debriefs, the 2-challenge rule, which means that you give a message, the receiver of the message has to repeat back the message. If the sender of the message does not hear a response, then you send the message again. And if that doesn't get you anywhere, then you've got to go to somebody else. And that's kind of what nurses know well as going up the chain of command. And right now we're working on bringing out a new interprofessional education piece that is integrated content, which means it's not a course, but it is implemented within the different professional courses. Between the College of Medicine and the College of Nursing to start to pilot, and then we're going to scale up, adding the College of Pharmacy and the School of Public Health. We require team steps master training of all the faculty facilitators, and then all the students will also train. And what we're really focusing on is the social and ethical dilemmas in healthcare, the social determinants of health, and we're including 5 cases in this particular integrated content rollout. And you can see the objectives here. I'm not going to read them to you, but as you can see, they're based on the IPEC Core Competencies, and we're using several sub-competencies. Next slide.
We have about a minute left.
Okay, well,
Thanks, Susie. That was great timing.
yeah, so go ahead.
So Dr. Chapa and White Corey have spent some time sharing with you the content, what is IPE, what are the core competencies. They've shared with you their case studies where they have created simulations with interprofessional simulations, and then also integrating interprofessional content. And now we'd like to shift into a session where we are a part of the session where we're really discussing this further in depth. So we will take your questions, your comments, any type of information that you would like to approach here. Now's the time.
Hey, Miss Chris,
Yes.
can you go back to that last picture? I just want to share something with everybody.
Sure.
So this last slide, guys, so this was not a photo op for this presentation. This is during one of our IPE sims. So the people in maroon is our nursing students. The white coats obviously are my medical students. I gotta tell you, one of our highest student satisfaction rated events in our clinical year is this simulation. So just, it's not like a class and they sit there and they're in little tables. They are the nurse and the doctor. Our medical students are told that they are the intern. Our nursing students are the patient's nurse, and they go in for a postpartum hemorrhage. And we observe, like Hunger Games, in the control room and throw things at them and see how they respond. It's real world. We have a pseudo labor and delivery suite in our sim center. Same thing for our eclampsia patient. So this slide has a lot of stuff. I don't know if you all get what's on this slide. I mean, there's a lot of stuff of what we're doing. We teach team steps together. Nursing students, medical students, pharmacy, or public health, and they do team steps, how to communicate together, and that's, of course, embedded in the curriculum. We do simulation in the clinical year. We're now launching this social dilemmas in healthcare, which our medical students and nurses and pharmacy students and public health are going to function like an ethics board on Zoom. So we're going to say, hey guys, here's a case, for example, of genital female mutilation. Parents want their little girl to be circumcised. For those of you who don't know what it is, you can look that up. Okay, you all hammer this out as an interprofessional ethics board and you come up with a solution. Groundbreaking. All colleges coming together to work together to solve not theoretical issues, but real clinical dilemmas, and they're learning from, with, and about each other in a real clinical way. So this slide gives you 3 ideas of what to do. You can teach team steps together. You can have an integrated ethics course together. You can do simulations together. And I'm telling you, it is far worth the pain, sweat, and frustration to get it up and going, because it works.
So I noticed in the chat that Tracy Hicks has a question. Tracy, why don't you ask the group your question?
Hi, hello everyone, let me unmute. So I was just wondering if the team approach was inclusive of both nurses and nurse practitioners.
So that's a great question. And we are doing our interprofessional simulation between undergraduate nursing students or pre-licensure nursing students and medical students. We do have plans to, and that's the same with the integrated content that Dr. Chapa just described very nicely. And we will be integrating the nurse practitioner students. We have a family nurse practitioner program here that we hope to include in this too. Now they also do their own interprofessional activities, but that is a separate thing that we're not talking about today.
Oh, okay, I understand. Thank you so much, I appreciate it.
Other questions or comments?
I have a question for our audience, our participants. So if anybody could, from your institution standpoint, I mean, everybody, here's the catch. We all need to do this. And I don't want to say that as you don't want to just do this to check the box because it's part of our accreditation. It is for us. You've got to be vested. You have to want to do it because you have to believe in what you're doing. I believe that this is a value. I believe teaching my medical students OBGYN is a value. But everybody has an obstacle. We've got ours here and we're working through those, and I'm telling you, those obstacles are melting away at record speed because we're having more and more buy-in. But I'd like to hear what some of your obstacles are, either real, like maybe you don't have faculty, that's a real thing, or perceived as a point of discussion.
Hi, this is Jamila Banu. I'm from UT RGV, way down near the border. And it's a fairly new institution. And we had an IPE that was pretty active when we were still UTPA. But when we merged and became UT RGV, then it came to a standstill because of all the logistics and people working out and a lot of changes in the faculty. But now there is a push for it, and the School of Medicine actually has been more taking the initiative more than the other schools. But then the problem has been trying to integrate the rest of the health professions with the School of Medicine, and slowly we are starting to build that group here again, or we are kind of regrouping and building it all over again. Just wanted to tell you the status here.
Well, Jamila, as a small world, I wanted to tell you that you actually have one of your OBGYN, you have an OBGYN residency program.
Yes.
Correct? You have one of my medical students there at UTRGV. So again, very small world.
Yes.
But you know what I see, Chris, eventually as this pilot that we're doing of ethics in healthcare, assuming that this works, and I have no reason why it wouldn't, why not? Once we have proof of concept, and we're launching January, that we say, let's involve, and we've talked about this already, schools that have social work. We don't have a social work program. Let's involve UT Rio Grande. I know we're A&M. We can play with each other. It's okay. We can have UT on our, why not expand this as a Zoom, because this is all virtual, to bring students together, even from across campuses. Well, I mean, it's not impossible. As Ms. Shelley said, that quote always comes to mind. We can't do that. There's no way. Why? Until you try. So there's always opportunities, especially to the Texas Consortium, to do IPE together.
So I noticed that Lacey Harrison mentioned that she has a small program and that money is an issue. And isn't money an issue for everyone, especially in these austere times? Dr. White-Corey, did you want to make a comment about that?
I did, because I just want to encourage Lacey, because I think, first of all, you need some champions. And when we started this in 2013, it was voluntary. I approached the then coordinator of the OB clerkship to do this, and he bought in, and now, and then Dr. Chapa came and bought in, and we just did it. We incorporated it into the course that I teach, which is the Women, Newborns, and Families course. That's all about OB content for the undergraduate nursing students. And of course, Dr. Chapa teaches the OB rotations for that clerkship. So, and somebody else mentioned that they get forgotten about and is just doing IPE by themselves. And I'm like, you go, that's awesome. You're a champion. And sooner or later, people will notice what you're doing and they'll want in. I mean, that's just my opinion. But Dr. Chapa, you have a comment?
I mean, you're right. It's got to start with somebody. And I think Chris can send out a link. Me and Ms. Shelley, we did an echo about 2 months ago, specifically about our simulation. So this is not the purpose of it. We wanted to talk about globally what IPEC and IPE is. But we did one specifically on what that sim looks like. And I'm sure, and that's archived through ECHO. So if you're interested in what that sim would look like, I'm sure she can send that out. But you're right. I mean, man, starting something is just a beast. Let's just be honest. But it's got to start somewhere or it'll never get done.
Thank you both. I appreciate it. I'm the director of IPE as well as simulation for our Master of Athletic Training program. We have about 22 students, and we've started working with our dietetics group, which has been awesome because we're both in the same department. But everyone else within our college, like there's no other health science programs. We do have a College of Medicine that's new at the University of Houston, which is awesome. So we're working on simulations, but as you guys probably know, the schedule and the way the classes work are a little bit different for College of Medicine than everyone else. So we're still trying to work on times to get everyone together.
And I want to say that that was the biggest challenge for us when we got this off the ground, was just getting the schedules to coordinate. But we had buy-in, and so we made it happen. And that's something I hear from Dr. Chapa all the time is, okay, we're just going to do it. We're just going to do it. With this integrated course, it's all online through Zoom. And so scheduling is not as much of an issue. So I don't know, maybe these times can bring more opportunities for interprofessional practice with the other health professions that you want to work with. But good for you, Lacey. I'm so proud of you. That's so awesome.
Lacey, you know what I even see from a medicine standpoint? I mean, that's a great general surgery clerkship and athletics IPE. I mean, trauma. If you're doing sports injury and you get into even family medicine, because there's the sports medicine track or fellowship after family medicine, that's a great simulation to bring in. So you just got to approach somebody and get them on board.
Yeah, we've definitely been working on that. The College of Medicine has been helpful because my money comment was more towards things like standardized patients. Like we can't afford that as a small program within a department within a college. So our College of Medicine has been awesome, and we're hopefully going to be able to kind of share some funds and work that out as well.
But you know what I heard from a buddy of ours who was in Dallas. So when they first started, you have an abundance of standardized patients. Those are your faculty.
Well, we have 3 faculty. There's only 3 of us, but we use athletic trainers in the area, and that's been really cool. Yeah,
for sure.
That's
Dr. Chapa,
awesome.
maybe you can also talk about the abundance that we have in terms of standardized patients for Disaster Day. Who are our patients there?
So as you all may or may not know, A&M has traditionally run and continues to, even in the pandemic, the largest student-run disaster prep in the state. And it's all colleges involved in a disaster response. And you know who our SPs are? Our first-year med students. Because they may not have pathophysiology or a therapeutic basis, but they can be moulaged and look like they broke their leg. So you've got people. You just need to get them in and I would make that an elective. Hey, you do a medical education elective, then they get somehow, credit, and they come in and they participate. They're learning from, with, and about each other. You just got to be creative from that. These pilots that we've done, they get credit for that, for participating. They're trailblazers. And if we ask something from them, it's fair that they get something in kind, and we give them academic credit.
And Dr. White-Corey has a historical perspective on this as well, about where else you can get SPs. Your comment in the chat.
Oh, yes. Sorry. Yeah, we have a lot of community involvement, and that's one of the beauties that I love about our particular community, is we have a ton of community members that just love participating in Disaster Day, in addition to some of our students. Yeah, and it's fun, and they just do it out of the goodness of their hearts.
Tracy, I'm wondering if you can talk a little bit about your comment in the chat.
Sure. So I am new faculty at TCU, and I have the opportunity to start the psychiatric mental health nurse practitioner program there. And they may be doing something like this, but I feel like when you're dealing with a team, it's important to realize who is on the team. And even if they're hesitators or obstructors, you got to just bring them to the table and say, just kind of analyze what their thoughts are, because usually it's tied to knowledge deficit, or, what can you do in this, in this situation to help us make this successful? And lots of times you get buy-in that way.
And I hate to throw this card out, Tracy, but you're absolutely right. It's got to be organic. But the card that always works is, hey, your creditors think it's as important. And when you get your site visit, they're going to ask you, where's your LCME 7 standard? That's what it is for us. That's IPE.
Exactly.
So it's all about, yes, you want to do it organically, but guys, beyond this push and just belief that we're doing something of value, we're trying to leave a legacy behind, is you're not going to be around if you don't meet this standard. You've got to incorporate it, hopefully with the right spirit, right?
And I think that actually circles back around to a question that Robert Catena had. Robert, can you share your question with us?
Yes, thank you. I'm just wondering, in these challenging circumstances for budgets these days, there's very limited budget to go around. So I'm just wondering if there was any lessons learned on that you can share that got senior leadership on board to the importance of doing IPE, how we can measure those outcomes, what's that return of investment that we can show them to really demonstrate that IPE is essential within our healthcare systems.
Chris, do you want to take that? I've got a short answer, but probably best from the IPEC
Sure.
office.
So my office is centralized. We still have decentralized IPE, but from my perspective, the colleges come along at different rates, right? And some of that's historical in terms of when their accreditation mandates came out. Nursing and pharmacy were a little bit earlier. Their accreditation language is a little more prescriptive. It's not conditional. Then you get a paragraph from medicine that is kind of fuzzy, just that they're responsible for it. And so the leadership is responding to that accreditation language. And so if it's been around for longer, they're probably further along. If it's not been around that long, they're coming along. And it depends on whether it's conditional or prescriptive. So that's just sort of setting the groundwork for how leadership is going to perceive this. I think you can make a really good business case to leadership to move this along. And that is that with tight resources, you can actually conserve some of your funding by pulling everybody together to do the same thing. We have 5 colleges here. If 5 colleges did 5 different things for IPE and it wasn't coordinated, we'd be spending more money. So making that case for saving money, making the accreditation argument, but really going back to what Dr. Chapa started with at the very beginning, it's really about better patient outcomes. It's about better student training. And so you have a lot of different arguments that you can make to your leadership, depending on what you think will resonate with them.
Well, it's also a draw for applicants. I've got 2 undergrads pre-med who would shadow me last year. They're now in our M1 class, our first year med students. One of the reasons that they chose here, outside of the fact that they were already at A&M as an undergrad, was that they wanted to be part of Disaster Day. They'd heard about, isn't that crazy? I'm like, well, what about the rest of the training and the rotation? Oh, well, I've waited. I've heard so much about Disaster Day in person before the pandemic. But my point is that IPE piece influenced 2 members to go, no, I want to participate in that because they want to go into emergency medicine. So very unique. So that I never would have thought about that. But while we're talking about accreditation and everything else, students view that as a plus that they can train and be able to put on their resume that they are collaborative team ready. And that's going to look great at residency applications.
Patricia, talk a little bit about the turf battles and some of the other barriers that you're commenting on in the chat.
Sure. Good morning or good afternoon. Because of bandwidth, I don't have my camera on, so that's why you don't see me. But I did have a textbook that was based on interprofessional care. And in my research, I found that TERP issues can come from more than just, the patient or the student or the organization. They come from various different backgrounds. But people are afraid of stepping on toes, and they feel like they're this is mine, and if I engage with you, then it kind of takes away from my personal identity. And so that was one of the areas that I saw. Of course, there are lots of other areas, ambiguity and loss of autonomy and things like that I dealt with when I was writing the textbook. But I think things probably are getting better. And I wish I could say that we were in a position that we are looking at IPE, but I'm at a new program, so I think it's going to take some time before we get to that step.
Ms. Chris, I have to intervene here on this one because this is a big point, and I don't want to run out of time either, but this is why if your institution can consider this, it actually works very nicely. Having Chris is our institution's referee. Do you see how this works? Because she is neutral zone. I mean, let me put it back out. When we're having this discussion within our college right now, to be very transparent, I don't want the charge of IPE alone for all the HSC, because people are going to view that's a medicine problem. I don't want the IBC football to land on Miss Shelley, because I know my peers are going to go, that's in College of Nursing thing. That would be disastrous. I think so the way that this is set up in our institution, everyone's different, is that there's this Office of Interprofessional Education, which is neutral zone. So that's not Texas A&M or UT. We need she's Dallas for what the old Cotton Bowl used to be for A&M and UT. It's neutral. So that now we come together with the idea of neutral territory, and all the spikes fit into that. That works. I'd be happy to lead IPE, but people are going to have the exact same thing that you're saying, Patricia. Miss Shelley would be happy to lead IPE, but we're going to have this. I think we've been successful because we have this centralized/decentralized model, because I have autonomy as director of IPE in the college. Miss Shelley has autonomy with the College of Nursing, but we all can come together at the moderator at arbitration table, which is Chris.
Time to wrap up.
Great. Well, thank you all for a very robust discussion. We really appreciate your participation today. I want to thank our presenters, Drs. Chapa and Shelley White-Corey, for their work on this and their insights. It's also been really great to have people not only from within Texas A&M, but people who are coming to join these discussions to enrich them.